Hello and welcome to CDC Profiles. Our featured resource person for this episode is Dr. Randy Nicolas. Doc, good to have you.
Good afternoon, Mari. Thank you for having me on.
Doc, can you brief our audience, give us a little background on your educational achievements and current field of expertise?
Sure thing. I graduated College of Medicine at the UP 1991, and afterwards I went to general surgery for 5 years, another 2 years in thoracic cardiovascular surgery, and another year in England, where I had some experience with at the Royal Brompton before going to the Mayo Clinic for advanced cardiac surgery.
Wow.
And
And your current focus is now?
Yes, after I returned home in 2003, my current focus now is cardiac surgery.
Oh.
So mostly congenital. So I deal with children and pediatric patients, but I still do an occasional adult patient once in a while. Yeah.
For what? For practice, or when you're asked to?
No, usually it's funny. It's a funny thing because since you deal with the children, sometimes the parents come back for some heart problem as well. So
of course, surgery on children is much more difficult because they're much smaller, right?
And the reason being is that not only it's smaller, but anatomy-wise, you need to correct it, and sometimes it takes a lot of artistry just to get that thing right.
Okay. Doc, can you tell us what your initial reaction was to the news about COVID?
Well, first of all, of course, as any doctor would probably say, how it would affect the practice and how how our health system could cope, knowing that the health system does have its limitations anywhere in the world for that matter, but mostly in the Philippines as well, since compared to our Southeast Asian neighbors, I think healthcare here in the Philippines is a little, it's playing catching up. So that was my main concern, how it would affect us.
As a surgeon, would that concern you a lot? Would COVID concern you a lot?
Absolutely, because hospitals need to realign, and they need to realign all the resources towards the expectation of COVID patients coming in and the severe patients being treated long term. So many of the resources, not only resources, but the manpower as well. Many of our operating room nurses, our recovery room nurses were reassigned, and our residents were also given new tasks as well, not necessarily pertaining to the practice of cardiac surgery, but things like that was really, really changed. And as consultants as well, we had to relearn many things. Of course, as a heart surgeon, we absolutely know nothing about taking care of a virus-stricken patient. So that in itself posed a lot of problems. That being said, though, because we are very highly specialized as a heart surgeon, we were usually called to the front lines to mainly insert central lines for patients with COVID, so that you could give all your medications without having to. Yes, and
I learned something new. I never knew that you needed a surgeon to do that.
Yes.
Okay. You have, from a previous conversation, I understand you have health challenges of your own.
Yes, sir. In 2012, so that makes, I'm on my 9th year already. So I am post kidney transplant since 2012, and I have been on immunosuppression ever since. But despite that, I still I still enjoy my job, even though I need to go to the hospitals and operate on, you know, even charity patients. It's still quite fulfilling and challenging at the same time. So it's still, I'm still very much focused on my practice up
Could
to this
you
time.
could you lay out, Doc, for our lay audience how that poses additional difficulties for you? How COVID poses additional difficulties for you as an immunosuppressed?
Yes. Um, in order for a kidney or transplant recipient to be able to accept the organ that was transplanted into themselves, they need to take medications, powerful medications, to bring down your immune response. Realistically, everything that you put in will be recognized as foreign, and your body will try to get rid of it. So, so there are many medications available that help sort of temper the immune response to your to the rejection, so that the organ that was transplanted may last a long time. And I just thank God that until this time I've had no problems whatsoever pertaining to the transplant.
So did that create in you an additional interest to explore COVID more, to learn more about COVID?
That's a very good question, Mary. Because since it was personal to me, yes, uh, I did some research and some readings as well. I poured over all the available information regarding therapeutics, and I seem to concentrate on a few of these therapeutics, which showed more or less a lot of promise. Yeah.
And what did you find?
Well, there are some. I did not dwell too much on the on the medications that are used as a frontline medication, but I went to more to the experimental drugs.
Okay.
So mainly the monoclonal antibodies, because since viruses are just an immunologic, aside from a virologic disease, it's also an immunologic disease, meaning to say you also need to contend with how your body will react to the presence of the virus. Yes, and most of the promising therapeutics that I have seen were targeting the immunologic part of the disease, how your body reacts to the virus. If you can see with all the statistics, most of the patients who get COVID will recover on their own, and they will develop some degree of immunity to the virus on their own without any active medications. It's the few that will have a hyperimmune or a hyperactive immune response to the virus that really get very, very sick, and some unfortunately pass away.
Okay. Can you tell us about what you found with the specific
Yes,
drugs?
yes, there are three drugs that sort of caught my eye. One of them is a monoclonal antibody cocktail by Regeneron that was given to the President of the United States when he got COVID. Basically, what it does, it's an antibody that targets the virus itself. It prevents the virus from entering its target cell. If you think about it, the target cell of the virus has many doors, and the virus needs a key to enter one of those doors in order for it to infect that cell. And what the antibody cocktail of Regeneron does, it blocks the key of the virus so that it can't enter the door. So it prevents infectivity. The other medication caught my interest because of its application in heart surgery. It's an inhalational drug called aviptadil.
Okay.
And what it does, it prevents or it even suppresses the effects of the acute respiratory distress syndrome, something you've read as ARDS. Yes, and this is what actually actually causes many of the patients who are very, very critically ill to require ventilation or a respirator to breathe. It's because of the ARDS. And the inhalational drug, VIPT, makes the or mitigates the effects of the syndrome to the lungs, such that the lungs are not as damaged as without the drug. The last drug that I was really interested in, that really showed a lot of promise, was another monoclonal antibody called Leronlimab. And this drug, what it does, if you think about the number of deaths that occur from COVID, a majority of them would die because of something we call the cytokine storm. And I know a lot of people have read this on the internet and on publications. It's the cytokine storm, or the immunologic response to the virus, that kills. And this drug, leronlimab, targets the root cause of the cytokine storm, meaning to say it doesn't target, if the cytokine storm were a tree, it doesn't target the branch, it doesn't target the leaves, it targets the roots. Yes, the root cause of the cytokine storm is what targets it. And I'm really happy to tell you that last Tuesday in the US, the company that makes leronlimab just announced that their phase 3 trial for in the severe and critically ill COVID patients has been given a green light to continue unto completion. And this was done not by the US FDA or not by the US National Institute of Health. It was reviewed by an independent board. It's called the Data and Safety Monitoring Council, and it's independent of the US FDA. They're a powerful group, and they can do three things, just three things. And if you think about the three things that they do, it's like a traffic light. They can give you a red light, meaning to say you need to stop the study because it's not going to produce any good results. Mm-hmm. Secondly, they'll give you a yellow light. They say you can continue with precautions. Now, the precautions would be modifications and everything. Leronlimab was given a green light, meaning to say they can continue because the safety was just absolutely impeccable. And the results, the preliminary results, were very, very promising. Meaning to say there were some critically ill patients, many of them on ventilators, some of them on life support like ECMO. ECMO meaning to say it's an artificial lung that breathes for you. Your lungs don't even have to function. This machine can breathe for you. It's called ECMO, ECMO. And many of them were on that machine, and many of them survived. Wow. So this is the first drug that has been given the green light for a phase 3 trial for COVID in the US.
Okay, can you give us an estimate on, that's leronlimab, right? How far away do you think it could? Of course, we know we're talking estimates here. Now that they have the green light, how much longer before it becomes mass-produced and locally?
Yes. Fortunately, I have a direct line to many of the management staff in the company as well, and it's another story, Mari, how I was able to get that. But I do have a direct line to them, and the estimate is that they will get their second interim analysis, meaning to say they reach 75% of enrollment into the study by end of November.
Okay.
And if they're still given a green light to proceed, hopefully by mid-December or end of December they'll finish enrollment. By early January, it'll be ready for review by the US FDA.
Just to clarify, when you say enrollment, you're talking about looking for patients to sign up for the trial.
Correct. Yes, Mari, you need to people need to understand, your listeners need to understand, it's very difficult to enroll a patient in these studies because you need to tell them there is a chance that you will get placebo.
Okay. Wow, that's
And
right.
you
Okay.
and you're severe. Meaning
Right.
to say you're on the brink of being
Okay.
on a ventilator, or even critical. Meaning to say you're grasping at
Right.
straws,
Right.
right?
Your
And
life is at risk.
correct. And they need to tell you that
Mm.
you have a chance of, you know, being on a placebo rather than being on the drug.
But what's the
So
process, doc? Because if you don't have a lot of time working with patients in that condition, so when they say yes, they're already in the program, and is it an issue of as you keep enrolling patients, that's how you get from 75 to 100%? Is that how that works?
correct. There are assigned hospitals in the US. Not any hospital or
Got
not
it.
any doctor can administer the drug. The the drug is on the study rather is only available in certain US hospitals.
Right.
Also in the UK, I was informed that the UK was already approved. We tried to get approval also for the phase 3 trial here in the US, here in the Philippines. I'm sorry, but the big problem was the logistics involved because many of the laboratories that the study requires, we did not have
Okay.
locally. And we needed to send serum samples of each patient
Mm.
to the US just for analysis. So it would make it a lot more difficult.
All right. So once they get past this, did you call it the DSMB? Is that right?
Correct. DSMC. Yes.
DSMC. From the DSMC, once it passes, gets past phase 3, then it goes to FDA.
US FDA. Correct.
Okay. But if it clears
And
the DSMC, is it possible it will not pass the FDA?
that is a very good question. That um, if we were not in this pandemic, then maybe the answer to your question is yes, there is a huge possibility. But because of this pandemic, they, everybody's looking for
All right. Got
a
it.
reliable therapeutic. So you have to look, Mary, you have to look at remdesivir.
Mhm.
Remdesivir was passed on not because they met any of their endpoints. Remdesivir never met any of their endpoints.
Ouch.
The only the only data that they were passed was that remdesivir seemed to decrease your length of stay in the hospital by 4 days. It did not affect mortality, and it did not affect the possibility of you going from moderate to severe or severe to critical. It did not prevent that. It's an antiviral that does not decrease serum viral load. So they set a very low standard for approval.
And I understand it has side effects that are serious.
You know, serious side effects. If you have just a slight problem with your liver, you no longer are a candidate for
Remdesivir.
remdesivir. On the other hand, leronlimab, there has not been a single adverse side effect reported with the administration of leronlimab. And the nice thing about it is it can be self-administered. You don't need to go to a hospital to have an IV connected and an infusion started. It can be, it's something like an EpiPen. If you have
Okay.
a severe allergic reaction, you can get your EpiPen and just stick it into your thigh or into your abdominal wall. It's the same thing with leronlimab. It's a self-injectable, humanized monoclonal antibody.
And how many doses would you need of leronlimab to, of course, depending, I guess, on the severity of
The
your.
severity.
Right.
That's another very good question, Mary. The doses are once given once a week, subcutaneous once a week, and by far a majority of the patients will improve with the first
Wow.
with the first injection. But they will be required to have another administration after another week. So 2 doses, usually a majority, I think 86% will already respond favorably. Those with severe will require at least 3 doses.
All right. So if someone were to go through that and they're ill with COVID, they get the leronlimab, and after 3 doses they're better, are they immune? Or is that still under debate?
Oh, yes, well, that is still under debate.
Okay.
But this is the thing, Mary. You don't. Leronlimab does not destroy the virus. It doesn't attack the virus. It has nothing to do with the virologic phase. It allows the body, or it realigns the immune system so that the body will develop its own immunity to the virus. You can develop it on your own. It's just preventing the severe immunologic effects that the presence of the virus in your system can cause.
All right, so that's leronlimab, and then there's aviptadil. Is aviptadil, you said it's experimental, so it's not yet, another drug that's not yet available. How far along is that?
Aviptadil actually is already approved.
Okay.
It's made by a Swiss company, and it's already approved as an inhalational for ARDS, for acute respiratory distress syndrome. So yes, the inhalational formulation is already approved. It's available only, I believe, in Europe and in North America. I'm not sure if it's available in Japan or Korea, but I was told that it was only available in Europe and it's in North America. Regeneron is experimental, and they're a little bit behind on the studies compared to leronlimab. So it'll take Regeneron a little bit more time to catch up and to get approval.
Of course, this is speculation, but do you have any idea why Trump would choose that of the available drugs?
Another difficult question to answer.
Well, it's speculation anyway. We're just guessing.
Yes. I would believe, since Regeneron is a huge, well-known company in the US, that's probably why. It has a very good track record. Leronlimab, on the other hand, is made by a small startup biotech company in the US, and it doesn't have any name recall yet. For example, when you say toothpaste, you always say Colgate.
Right.
And that's, and something like that. So when you say something for COVID, then you'll say, oh, that should be Regeneron. Yeah.
Okay, Doc, I'm going to bring you into a little bit of a more controversial topic, if you don't mind. But what would you have to, because I know you have a particular concern, especially with your pediatric patients, with your child patients that need surgery. Again, from that previous conversation, you were saying that there's a window within which the children need to be treated, the operations need to go through at a particular point in time. But because of the lockdowns, you've not been able to do that. Could you go into that, explain to our audience what more about that?
Yes. I believe it's not controversial,
okay.
Mary.
Well, the issue of lockdowns is a little controversial.
Yeah. The thing is, Mary, we really don't know the toll that this lockdown has taken on our patients. Since March, we have been scaling down our operations tremendously. Even before the lockdown, we have already had a backlog of several weeks.
Wow.
2 months. In the heart center, some of our patients were looking at 8 months backlog.
Right.
So you meaning to say if you needed surgery, you'd have to wait, close to a year just to have surgery done. Not all, Mary, not all.
Of course.
But there were some. Now, with the lockdown, the backlog has grown tremendously. And I fear, of course, I don't have the numbers to back it up, but I fear that we might lose a considerable number of these children because of the unavailability of urgent care. And maybe towards the end of the year, when we collate all our numbers, we'll be able to get a very, very good comparison from the year past. But this is the fear I have, is we really actually do not know the number of people who have passed on as a direct result of the lockdown, and not as a direct result of COVID.
But here's my problem, Doc. Why was this not even considered when they first thought of the lockdowns? I understand, okay, if you're looking at the lockdown from a 2-week perspective, a 4-week perspective, maybe even an 8-week perspective. But when you're looking at extending, you're a doctor, you're in charge of the Department of Health, you have doctors working with you. How could people have not considered, experts have not considered what was happening in other fields of medicine apart from COVID?
I believe the primary goal of the lockdown was to prevent overwhelming the medical system. And it was also meant so that it'll give time for the medical system to adapt to the pandemic. Now that we're pretty much we already have all our protocols in order, we have all our precautions in order. We have been slowly opening up all the other services. So yeah, I believe the many in the government hospitals have been realizing this and have been slowly opening up. But the main purpose of the lockdown was not to overwhelm the medical system. But that being said, Mary, the concern of my colleagues is that if you reopen, and this is the main concern that many of my colleagues have, if you do reopen the economy, and it does produce another surge of patients requiring urgent care, then we're back to square one. And that's their fear. That's the reason why I have been, since March, I have been doing my very best trying to get in reliable therapeutics into the country, so that, if you have a reliable therapeutic, your colleagues as doctors, even if you do contract COVID, God forbid, Mary, but if you do contract COVID, at least you have a reliable therapeutic in the background that you could rely on. Yeah.
And you've just brought us 3 new ones that many are not aware of. We have others that are already existing. But where do you see this problem of COVID taking us in the next few days or weeks?
That is very hard to answer. I believe we're already at a point wherein we need to decide how to proceed further, whether to reopen, whether to remain in remain into a modified community quarantine or not. And I believe, personally, that the government is trying to find a balance in order to reopen, restart the economy, at the same time keeping all the citizens safe. As doctors and as concerned citizens, our role is to help try to get reliable data around the world and local data to the people concerned, the people who make the decisions. And that's what I've been also trying to do. In my capacity, of course, I'm just some people will just say, but you're just a surgeon. How come you're
just a
involved in all
surgeon?
this or something? But I am a concerned surgeon. That's what they don't know. I've been working in the background, and it's come to a point wherein I already have been able to establish a local pharmaceutical tie-up with the makers of Leronlimab in the US, and they have been appointed already as the local distributor. So we already have the foundation set up. So when the drug is already approved in the US, we are ready to bring it in.
All right. Yeah, just to be fair to the government and the people at the Department of Health, we understand, just to lay out the problem some more. If you were to open the door for children to have surgeries, let's say at the heart center, then the problem is how do you get the children from their homes to the hospital and the surgery? Then you'd need staff. The parents would, of course, the transportation would be necessary. So you have all these people that are involved in bringing one child to the hospital, and of course that means opening up. But on the other hand, studies have been out since, well, I don't want, some months back, that show that children are not particularly vulnerable to COVID, and that they're actually pretty safe from this drug, from COVID, rather than as opposed to the flu. On the other hand, their parents, if they have these are children who need congenital surgery, surgery from resulting from congenital disease, then generally their parents are also young, right? Again, they're well below the age, which is the vulnerable age. So, if we were to follow the statistics, then it should not be a problem. At least opening up that area of society to getting the surgeries, the operations, and the care, the health care that they need, right? Just to breathe some hope into parents who might be in this facing this kind of problem right now.
I agree 100% with that statement, Mary. The only precaution I have for our patients with heart problems is that during the first few months of the pandemic, during my conversations with my colleagues abroad, they noted that if a post-op patient, a post-open heart surgery patient, does contract COVID, it tends to be a little bit more severe, and this holds true also with the children. They may be a little bit more resilient when it comes to a COVID infection, but if
combined with the heart disease,
correct, they are at particular risk.
Okay.
But I still believe that we need to find a balance, because we now have standard of protocol when we have patients for surgery. You need to say they need a swab test, and once they're negative, they can enter the clean operating suite right away, and recovery rooms are clean. Our nurses are required to have regular routine swab tests. Surgeons as well, we need a screening swab test, and then as long as we're asymptomatic and without direct exposure to any known COVID patient, then our next swab tests usually are several weeks down the line. Yes, we have our protocols set in place, so we are capable of attending to these patients, if we do open up.
Okay, Doc. You brought us some good news in the form of the 3 medicines that are undergoing trials now and are hopefully within weeks away or months away from release, hopefully.
No, I really do hope so.
All right.
Leronlimab would probably be the first one to be available.
Can you tell us if any of those can be used as prophylaxis as well?
Maybe because of the price. Because if you look at the price of monoclonal antibodies, those available
on the high side,
for rheumatic arthritis, for example, they're quite pricey.
Okay.
Even in the US, they're quite expensive. So, in use for prophylaxis, probably not.
Okay.
Yeah. But once you do require oxygen or require possibility of ventilation, yes, absolutely, it will save you from that, and it's shown to do that as well.
So, is there any other ray of light? Do you see any light at the end of the tunnel that we can end on? I mean, a little bit of a high note that we can end on. That's not so
Yeah,
dim.
that's so dim. Yeah, well, yes, actually, I had a recent patient. It was a charity patient, you know. So the child was a newborn child. Came to us wasting the child was actually born full term, normal gestational weight, but immediately after birth, the astute pediatric cardiologist noted um, the child was not doing very well in evaluation, needed complex open heart surgery, and they fought tooth and nail just to have this patient operated on. And this was a charity patient, meaning to say the government had to sponsor the child some way. And as surgeons, as doctors, we needed to render our care pro bono, completely pro bono. And fortunately, we were able to operate on this child at the child's, I believe, 9th day of life.
Wow.
And immediately after, the child sailed through complex open heart surgery very, very well. The child was pink, no longer blue. The child was gaining weight, no longer wasting away. And eventually the child went home COVID-free, including the child's parents were COVID-free when they went home. So it can be done. It can be done safely.
And this is how recent? Weeks ago?
2 weeks ago.
2 weeks
We
ago.
discharged the patient 2 weeks ago.
Excellent. Okay. Any other areas of special concern to you as a doctor?
Yes, actually, yeah. There was an article, and it was written by the one of the heads of the NHS, the National Health of the UK, and he was concerned because he handles a lot of cancer patients requiring chemotherapy.
Right.
Many of them have missed or have failed to initiate chemotherapy because of or not only chemotherapy, but also radiotherapy for their cancer and other forms of adjuvant therapy. And he fears that the toll of these cancer patients will outnumber the death rate of COVID by a factor of 3 to 1. And that is something that we really need to look into.
Right.
The direct mortality as a consequence of the lockdown is a big unknown. And if we look closely into it, we might find out that it is much, much, much bigger than the mortality from COVID.
Okay, Doc, final question. How do you flatten the fear as a doctor?
Yeah, well, that's why I've been trying to look into these therapeutics, because that's the only way I can reassure my colleagues. This pandemic has really struck close to me. I lost a very good friend, a colleague who's also a surgeon, and he passed on early on in the pandemic. I lost 2 mentors and another good friend. A very, very close doctor friend of mine lost both his parents from COVID. And so this pandemic has really touched very, very close to home. And, it's really difficult to reassure these doctors unless we have a reliable therapeutic on board and available. And that for me is the only way to flatten their fear, at least in the medical field.
Dr. Randy Nicolas, thank you very much for your time, sir.
Thank you, Mary. I appreciate it, and I enjoyed the conversation.
So did I, sir. God bless you. Thank you, sir.
God bless you. Thank you.